very welcome for this session. Thank you so much for that brief introduction. Next on our agenda we have is that a link has been shared in the comment section. Feel free to tap on it and attempt the pre-test session. As you attempt the pre-test session, feel free to type in the comment section your expectations of today's session. Type your expectations. If you feel like you would like to speak, and put up your hand and you'll be selected and you'll be allowed to speak. Thank you. Please keep typing in your expectations of today's session and also share as you also attempt the pre-test. Okay, thank you for attempting the pre-test. Next on our agenda, we have is a presentation from Dr. Waswa, a junior health officer at Mulago National Referral.
Once again. So, subcase. Presenting child female with a 1 week's history of reduced appetite, general body weakness. That later was followed by a 1 day history of confusion. A 20-year-old female, now we know any chronic that was referred from a peripheral facility, came with 1 week history of general body weakness, loss of appetite, non-projectile vomiting. The later was with a 1 day history of confusion. and unable to pass in urine for 1 week. She was treated for UTI and a UTI and clinical malaria. However, there was no improvement. For this cultural history from the mother. So, assessing this patient, hair was parted. She was with uncoordinated words. Breathing, she was in high respiratory distress with small breathing. She was slightly 22, however, saturating more than 95 from air. The chest was symmetric with equal air entry, knowledge sounds. Saturation, I assume it were cold. Recovery for less than 3 seconds. Short tachycardic, 221 beats per minute and regular. BP was around 1/64. Sounds 1 and 2 were hard knowledge sounds. So for this patient, we planes. We drew blood to carry out investigations, baseline. And gave IV ondansetron for she was vomiting. Stability, she was confused, she was speaking uncoordinated words. However, motor was 6 and eye opening was 4. She was restless and confused. Pupils were echoreactive to light. Did RBS 0.1 millimoles per liter. This was restless. Gave Mugan. The catheter was passed. Output. That time, time of insertion. The time of insertion of the catheter, she passed out. The bag collected 100 mils of urine, 100 mils, which was concentrated. IV Actrapid was given 6 IUs based on our weight. She has approximately 60 kgs. And then since labs were not yet out, she was given IV KCL. Exposure to the temperature was 37.2. Monitor vitals were to be monitored. So on secondary survey, she was sick looking, confused and restless in mild respiratory distress. She was dehydrated. No jaundice, no pallor, no cyanosis, however, with extensive hypopigmentation on face, lips, and hands. Serious normal active pericardium, apex beat, fifth intercostal space with clavicular, S1, S2 had no. Respiratory system was mildly tachypnic, chest symmetric, no tracheal deviation, normal percussion, not bilateral, equal entry sounds. Abdomen, normal fullness, soft and tender, no mass in organomegalies, no bowel sounds. ENT shared oral solids with no nose or ear discharge and pain. CNS were just confused with a soft neck, negative canning, about 4 centimeters, about 4 millimeters, and equally active to light. Muscle tone, power, normal. Muscle bulk, no joint pain or tenderness in the muscular system. So, sample history. Signs and symptoms, She reported to have been unwell for about 1 week, with general body weakness, reduced appetite, that was associated with non-projectile vomiting and dizziness, that were later followed by one confusion and failed pass urine prior to admission or referral to Mulago. However, that was all not associated with fevers, headache, chest pain, pain, loss of consciousness, or convulsions. There was unclear history of polyuria, and dyspnea that the mother talked to her about, weight loss that she attributed to being in Form 6, that she was stressed about box. No history of lower limb swelling or facial swelling. There are no allergies, food or drug, no. Medication she was only managed for UTI and clinical malaria from a peripheral facility with unknown medications. Past medical, it was just managed for clinical malaria and UTI. She had vitiligo of since 7, no any other chronic illness. She hadn't had any operations in major surgeries, blood transfusion, or in trauma. She was a student, third born of 4, 2 boys and 2 girls. Last normal menstrual period was not known, gotten from school. And for the events, she had a one week history of general body weakness, loss of appetite, non-projectile vomiting. Later became confused, and then anuric. From there, from all that, she was managed for UTI. From all that, we had a problem list, which had glycemia of 30.1, pneumos, was confused and restless, dehydration, and the resolving UTI. She was investigated. RBS was done at that time, which had 30.1. Even B1C was done, 14.4%. RDT was negative and BS was no parasites. CBC showed a mild neutrophilia. HB was raised and platelets were normal. Urinalysis showed ketones plus with glucose plus nitrates were negative, but some past cells and these cells. Some loculates showed baseline potassium was 4.8 and sodium of 160, slightly increased. Creatine 186 unimoles and 2.4, which are all increased. F2s were normal, since we didn't know the last normal menstrual period. We did a urine HCG, what was negative. So from all that, the investigations history, we had these are the diagnosis, DKA, DM with DKA, AKI, with candidiasis and vitiligo, with differential malaria, uremic encephalopathy or CKD from the renal function test. In our management, we had supportive and definitive, she was restless, give her a peridot, maybe or that's for the vomiting and omeprazole, because she was first day she didn't eat anything. So our request fluids, replace fluids, where I gave 2 liters in the first 1 hour, 1 liter in the next 1 hour, and 1 liter in the next 2 hours, and 1 liter for the next 4 hours. Target of having at least 5 liters in the first 8 hours. KCL was given 20 millimoles before we go back to investigations. I was after PID might bring down the sugars, and sugars were closely monitored our end. So after about 2 hours, 2 liters of normal saline in the first 1 hour, urine output, we had in our bag we had around 500 mils, which was trying to clear compared to the first one. Within 8 hours, 5 liters had been given. This was reducing, and potassium, we had gotten potassium by then, so KCL was stopped. Potassium was stopped. We continued with fluids such as bring down sugars and also challenge the kidneys. Sugars after more fluids, they got better as urine output was also improving. And on follow up on second day. We gave antibiotics, ceftriaxone 2 grams BD, rinazole 500 BD, 5 days, and caps fluconazole as urine output and fluid intake were monitored together with RFTs. She was now fixed for the sugars that gotten and then was closely monitored follow up another days for many things, but in this case I will look at my urine output and then the renal function tests. Day 2, we had a fluid deficit after 24 hours. We had put in around 9 liters and we had put out 11, so we had a deficit of around 2 liters. So we had to put that in the next plan of fluid she was supposed to receive. The ketones were clearing, however, renal function tests, urea was clearing and creatinine was clearing. So more fluids were given based on the deficit and maintenance fluids. Day 3, this was improving, vitals were all improving. Fluid intake at that time was 6 liters and output was 2 with a deficit of 1, which was included in the next plan to give her more fluids and also encourage oral fluids. On day 3, renal function test area was 8.8 and creatinine 127, really clear. Therefore, ketone that cleared, glucose was that. Sodium, potassium was 4.4, urea 6.2, that get back to normal, and creatinine was 99 unimoles. Is what come to normalized. Which was then used to try to hydrate her and prevent relapse of what had that. So this is just summarizing the tables. Uric catheter was removed on day after the kidney, after the renal function test had normalized. Which was measuring iron in the container, which we further monitored, and it was all getting better. Next, please. So on day 6, after all the medications were done and sugars were ranging to that, though we had some relapses about 14. Was discharged and linked to a nearest DM clinic in PG. Thank you very much.
Thank you so much, Dr. Waswa Sali, for that wonderful presentation. Next, if you have any questions, please type them in the comment section. They're going to be responded to by Dr. Nakalema Irene. She's responding to all chat questions. So in case you have any, keep them coming. Next on our agenda, we shall be hearing from Dr. Joseph, who will be presenting about etiologies, clinical presentations, and investigations in a patient with AKI and CKD. Welcome, Dr. Joseph.
Thank you so much. Thank you, everyone. Thank you, Dr. Waswa, for the case presentation. The nature of the case being a DKA, and all of us might be interested in focusing on DKA, but for the purposes of our discussion, let us focus on the acute kidney injury and the CKD and the related complications. So, from the basics of understand this topic better, we know that a normal person at least has a pair of kidneys, and these kidneys, their function is to make urine. The urine through the ureters, stored in the bladder, and then expelled through the urethra. So, if there is any either disease or obstruction or any problem at different levels, then it can affect the kidney function, and one will end up with either AKI or CKD. So, start with the functions of kidneys. We have acid-base balance, so in which the kidneys excrete the hydrogen ion into urine, or reabsorption of bicarbonate. So another function is excretion of water, excess water, and also regulation of body electrolytes, especially the potassium, the sodium, the phosphate, and the calcium. Then also regulation of blood pressure. So BPs regulate the blood pressure through the RAS mechanism, and also kidneys also synthesize or produce erythropoietin that helps stimulate the bone marrow, produce the red blood cells, and also kidneys the vitamin activation of its active form. So, of all the functions that I have listed, if anything goes wrong, one is likely to end up with either AKI and CKD. So, we shall talk about the etiologies and common presentation. Yes. So, kidney injury refers to rapid decline in kidney function that leads to subsequent dysregulation of the electrolytes, the potassium, calcium, phosphate, and volume. Then also accumulation of the toxic nitrogenous wastes that include urea, uric acid, and creatinine. So, the kidney definition says that one has acute kidney injury if their urea has increased by 0.3 milligrams per deciliter within the 48 hours, or their creatinine has increased by 1.5 times the baseline that has been there for 7 days, or if their urine output has dropped to less than 0.5 ml per kilogram per hour for the 6 hours. So that means that for you to detect someone have AKI within the 6 hours, you should already be monitoring as soon as you get the first contact with the patient, such that you should not delay to detect the AKI, because the earlier you detect it, the better. So AKI has causes that can be categorized as pre-renal, renal, or post-renal. Renal causes are literally the causes of AKI that are related to reduced perfusion, reduced renal perfusion that ends up causing kidney injury. The renal causes are the ones that happen within the kidney itself, and the post-renal are usually obstructive. Someone can be oliguric that is say forming less urine with AKI, or someone can actually be forming urine when they are having AKI. So we do not necessarily have to wait for someone to form urine at all for us to have suspicion of AKI. Next. Yes. So there is a recall criteria. So we say that someone is at risk if their serum creatinine is 1.5 raised times the baseline, or their glomerular filtration rate has reduced by 25%. The normal GFR is between 90 to 120 mils per minute per 1.73 squared. So if it has reduced by 25%, or their urinary output has reduced below 0.5 mils per kilogram per hour, for the first 6 hours that you got into contact with the patient, then you say that one is at the stage called risk of AKI. One is at a stage of injury if their serum creatinine has increased by ×2 the baseline, or their urinary output has reduced is less than 0.5 mils per kilogram per hour for the 12 hours. Or a person is at failure because their serum creatinine is ×3 the baseline. That means that for you to know all that, you should already be having the baseline creatinine that you should be comparing as time moves on. So you can, if you check someone's creatinine and it is any value, you cannot know how many times it is times their baseline if you didn't know the baseline in the first place. Yes. Also, urinary output is less than 2.3 mils per kilogram per hour for the 24 hours. Or if someone is anemic for the 12 hours, we would say that they will failure. We say someone is at loss of kidney function if there is persistent renal failure for more than 4 weeks, and someone has end-stage disease if someone has had complete loss of kidney function for more than 4 months. So AKI, because it is potentially reversible, it doesn't mean that it is always reversible. Actually, having AKI is a predisposition to having chronic kidney disease. All these AKI are something that could potentially lead to one losing their kidneys. So that was AKI, rapid loss of kidney function, literally within hours to days. But chronic kidney disease, on the other hand, is when there is kidney damage that is progressive in nature and leads to gradual or decrease in glomerular filtration rate. We say the norm is 90 and above, and this time sometimes drops from 90, sometimes less than 60. So if it takes more than 3 months, then we say that one is chronic kidney failure. So it usually leads to loss of nephrons and loss of function of renal mass, and in such a state, usually the nephrons undergo permanent irreversible sclerosis, leading to progressive decline in glomerular filtration rate. So it is a chronic condition, and the goals of managing it is to slow the progression. It may not necessarily be to heal the already damaged nephrons, but to prevent further damage of the nephrons that are still there. Yes, for it is categorized. Yes, the stage from stage 1 up to stage 5, where stage 1 we have loss reduction in glomerular filtration rate below 90 mils per minute per 1.73 meters squared. One is in stage 2, CKD, their GFR is between, if their GFR is between 60 to 89.
The baby is crying. Oh, we are coming. We're in town. You pass her, I come to her. Genesis. Yeah, I'm one.
Yes. So stage 3A is when GFR is between 45-59. Stage 3B is when GFR is between 30-44. Then stage 4 is when someone has GFR between 15-29, and stage 5, which is stage 5 OM stage renal failure, when someone has GFR less than 15. So we use creatinine-based formulas. There are 12 of them to calculate glomerular filtration rate. And there is a statement that cystatin C, if it is available, it would be actually better, especially in populations that have a smaller body mass, like children, because creatinine is proportional of how the muscle size of someone. So in children, their creatinine levels can actually appear normal even when the kidney damage is ongoing. So if you have cystatin C, then such people with smaller body mass, like who are malnourished, those who are amputated, then it would also give you a better picture in addition to creatinine. Then you would also have to take into the context of urine albumin, C, because in a normal urine, the glomerular filtration is not supposed to allow proteins go through. So if proteins are going through the glomerulus, then it's also an indicator of what? Of damage. Yes. Yes. So the causes, now we are going to talk about the causes of the AKI and the CKD. So causes of AKI, for the purposes of categorization, we categorize them to pre-renal causes, then renal and post-renal causes. Pre-renal causes, these are generally the causes that actually reduce renal perfusion. Anything that can actually reduce the perfusion of the kidneys can potentially cause pre-renal AKI. For example, renal losses. An example is the case that they have presented us. If someone has diabetes mellitus, they usually get polyuria. So you lose a lot of volume through urine, and you end up having a small intravascular volume that can expose you to a pre-renal AKI. Then you can also have use of diuretics. So many people, for different reasons, they are on diuretics, and sometimes overuse of diuretics or using them in higher doses would predispose someone to pre-renal AKI. GI losses, including diarrhea and vomiting. This one is especially among children. Someone develops diarrhea and vomiting, and in a short period of time, they have lost their intravascular volume, and that can predispose them to volume depletion, and thus a renal AKI. Cutaneous losses, for example, in burns. When people get burns, depending on their total surface area that's affected, they lose the volume. After losing the volume, of course, later on translates also to small intravascular volume that we again need to renal AKI. Blood loss in cases of accidents or any form of GI, maybe bleeding, so it can also predispose you to renal AKI. Pancreatitis that leads to extravasation of fluid and therefore small intravascular volume. All those can lead to renal AKI. Or all conditions that actually lead to a decreased cardiac output that could be directly or indirectly related to heart failure. For example, congestive heart failure or other causes of restrictive or cardiogenic heart failure, all of them could actually lead to a low cardiac output and therefore low renal blood perfusion and therefore leading to AKI. Next. So, or you could have systemic vasodilation. All these are mechanisms that can actually explain why the renals would receive less blood. For example, in sepsis, there is loss of vesicular tone and systemic vasodilation. Anaphylaxis, use of anesthetics. For example, local anesthetics can lead to systemic vasodilatation. While the BPs are cooling, the renals receive less blood, because in any condition that leads to an increase in blood pressure, the body prioritizes other organs like the brain and the heart, leaving behind the kidney. That's why they are always at the risk of getting kidney injury in case of anything that can cause low BPs. In addition to that, there are drugs that can actually potentially cause AKI. Now, those listed drugs, the NSAID, this amphotericin B, nephrine, and the contrast agents, they cause arteriolar vascular constriction as one of the mechanisms. Some of them have multiple mechanisms by which they cause AKI, but in this context, they cause the constriction of the afferent arteriole, leading to low renal blood perfusion, leading to AKI. Yes, so those were pre-renal. Now back to the renal causes. So these are diseases, or these are conditions that affect the kidney itself. And this could be the diseases, they could be autoimmune conditions, they could be different forms that affect the kidney itself and the function lowers. Among them include renal vessel obstruction, can have obstruction of the renal artery or vein, or vein, microangiopathy, malignant hypertension from other causes, scleroderma renal crisis, transplant rejection, or things that are actually related to the glomerulus itself, like anti-GM, glomerular basement membrane disease, good pasture syndrome, IgA nephropathy, pigment. So you see, like in conditions that lead to hemolysis, hemoglobin breaks down and moves in saturation and is filtered through the glomerulus. So it leads to obstruction of the renal tubules themselves, and leads the production of different reactive oxygen species, which leads to further kidney damage. Different crystals, there are drugs that actually cause crystallization within the kidneys, and all of that can cause intrinsic or renal causes of AKI. So we have drugs, different infections, and anticoagulant-related nephropathy. So about that anticoagulant regulation, there are people who have been on anticoagulants for long and they end up bleeding within the kidney itself, which causes more damage. Yes, so the post-renal causes, in summary, these are causes that cause obstruction of the urine. So once there is obstruction of urine, then there is pressure. There is accumulation of urine within the renal pelvis, within the collecting ducts, and that pressure eventually causes renal failure. So we can have obstruction at the level of the ureters, or at the level of the bladder, or at the urethral level, or if there is any form of like renal vein thrombosis, or urolithiasis, or neurogenic bladder, a condition in which the bladder is not able to contract and empty itself, therefore leading to accumulation of urine and accumulation of urine back up to the renals. This can lead to infection, or even can lead to other complications that can cause that. That's why even in management of AKI, it is not only the physician side, even the urologists, if the cause is obstructive, sometimes they may have a role to play and remove the obstruction. Yes, so if it is in neonates and infants, they can also get AKI if maybe they are bred around birth time, or if they get perinatal asphyxia, or if they can get renal causes if they have gotten like the mother, pregnant mother receiving aminoglycosides during the mental, or ACIs being given, like many of them have pressure, maybe, and it is managed wrongly using ACIs, would predispose the unborn baby to getting AKI. Or if someone can get congenital malformations that could dispose them to postural forms of AKI. So in children, etiology does not change much. It's also pre-renal hypovolemia. So they have a low small body mass as compared to adults. So if a child gets diarrhea or vomiting or any cause of volume loss, they are more likely to develop AKI so fast. So every time you're treating a child with diarrhea and vomiting, only think about the kidneys. So also they can also get intrinsic causes that include HUS, hemolytic uremic syndrome, and in that case, E. coli produces sugar toxin, and those toxins lead to different mechanisms through which the kidneys get damaged, and they usually cause the AKI in that way. So many children on our wards, they will come having maybe other symptoms, but if you do not pick out the renal function tests as early as possible, you can actually detect AKI when it has progressed to higher stages. Malaria can cause AKI in children, and it's a common cause also. Then also we have acute post-streptococcal glomerulonephritis, and that also can cause intrinsic AKI. Then you have post-renal causes that include posterior urethral valve, which could be congenital, would also have stones, tumors, and neurogenic bladders, which perhaps tumors and all that may not be as common as much, but you also need to know them, because you don't know which patient you may get. Next. Yes, so CKD, chronic kidney disease in adults, diabetes mellitus, just like our case. So accumulation, chronic hyperglycemia leads to formation of AGs and reactive oxygen species that lead to direct damage of the nephrons, and eventually someone who has uncontrolled glycemia, then they are more predisposed to getting CKD. Hypertension causes CKD, and also CKD causes hypertension. So because of pressure filtration leading to sclerosis of the different parts of the glomerulus leading to CKD, glomerulonephritis, polycystic kidney disease, chronic pyelonephritis. So someone can have, let's say, obstructive urine disease, let's say those who have maybe BPH also, then the urine builds up and maybe goes back, and they cause pyelonephritis infection, and they will end up, if it's not treated in time, they can end up with CKD. Different medications that include NSAIDs, that include diuretics, that include NSAIDs, diuretics, and different nephrotoxic agents like lithium could lead to progressive damage of kidneys. And if the insult is not rectified in time, it could lead to CKD. In children, we have congenital anomalies, like we talked about, in posterior urethral valve and other congenital anomalies. Hereditary diseases like Alport syndrome, polycystic kidney disease, glomerulonephritis. Now, for children, special attention should be given to nephrotic syndrome because it's a common condition that actually children present with, that if not managed well, or if patients not followed up well, they could potentially end up with CKD. Diabetes mellitus, type 1, especially for children, and also medications could also lead to CKD. AKI predisposes to CKD. So, so if someone gets AKI, should be detected as early as possible and given all the management as soon as possible, because if it is not detected in time, or if there is a recurrence of AKI, one has higher chances of getting CKD. And also, when someone has CKD, they are more likely to get AKI, because when someone is on CKD, they have other complications that come with them. For example, they have infection, they have many conditions that they will be on many drugs, which those drugs can actually lead to AKI. They are acute on chronic AKI. Yes, there is another interesting study that was done about TBs and anti-TBs. For long, it has been known that anti-TBs, like rifampicin, they cause AKI and kidney insult. But now this time, Professor Kalyesubula and Grace Kansime, they did a study about patients who had TB, and they would assess them before starting anti-TBs, and they actually found out that actually patients, even before being started on anti-TBs, they had AKI in itself. So it was concluded from that study that actually TB in itself can cause AKI, in addition to anti-TBs that have always been known to cause AKI. And then another interesting finding was that people living with HIV, given that they are closely monitored, they had higher chance of being like TB being diagnosed early. Yes, as opposed to people who do not have HIV, nobody cares about you so much if you don't have HIV. So people with HIV had earlier diagnosis than people who had TB alone. And because of that care that comes along with HIV, it was found out that actually mortality from AKI was lower in people who had co-infection of HIV TB as opposed to TB alone. That was a very interesting study. You need to find it out and read it. Yes, so common emergencies that are related to AKI and CKD are directly related to the function of the kidney itself. If we say it is related, the functions of the kidney is electrolyte regulation. So we find that if someone has AKI or CKD, they are not able to secrete the potassium out, so they will end up with hyperkalemia, fluid overload, hypertensive crisis, severe anemia. We said that the kidney actually produces erythropoietin. So if there is severe progressive CKD, one will not be able to produce enough erythropoietin. So they have infections, electrolyte imbalances, then uremia and bleeding. So the emergencies we develop depending on the function of the kidneys, and the presentation will vary from patient to patient. Another thing to emphasize on this is that someone can have AKI without obvious symptoms, or someone can have progressive decline of GFR from less than 90 to like 70 or 80 without necessarily showing you obvious symptoms. So it is our honor that every time you get chance to interact with the patient, find out how their kidneys are functioning. Do not wait for these emergencies, because they are not emergencies that you would want to have. Yes. Yes, so patient approach, if someone comes with those emergencies, now these are very many emergencies that if I were to present one by one, I would take longer than I was supposed to take. So in the patient approach, every time you interact with the patient, the first thing is to do the primary survey and find out what would actually kill the patient in the shortest time possible. Then 2, take the sample history, the short history that will help you troubleshoot if someone has a life-threatening condition. Then we do detailed history and secondary survey, because part of this could be in history. So if you jump the history, or if you don't do head-to-toe examination, you could lose on the subtle presentations of AKI or CKD related. Then you want to do other antigens, like doing the investigations and all that, such that you come up with the proper understanding of the disease. AKI or CKD, they're usually caused by something. So you need to find out what caused that, and then you manage. So in the emergency approach, you do that, then you dispose the patient to the department where they belong, whether nephrology or whether you need any other department. So, and in airway, what you are interested to know is the airway pattern, the circulations, the tongue obstruction, are there noisy breathing? In breathing, is someone breathing adequately? The key word is adequacy of breathing. So if someone is breathing but it's cyanosis, then that is not adequate. Then we want to give oxygen. Or if, as we've seen, people with CKD may present with pulmonary edema. They are having difficulty in breathing. That's when we want to probe the bed. And at 30 degrees, you give positive air pressure, give oxygen, and like that. Saturation, you are interested to know, are they having adequate perfusion of tissues? What is their capillary fill time? What is their extremities warm? What is the BP? What is the pulse rate? And what is the character of the pulse? Then go ahead and listen to the heart. As their pericardiogram, because there are other things that are related to uremia. For example, uremic pericarditis that is associated with pericardiogram and all of that. So in disability, what is their DCS and what is their RBS? One thing that you need to know that many people having CKD are usually diabetic and maybe on insulin, yet if someone who has CKD and is on insulin could actually present in coma because of hypoglycemia. That's very, very important. Then you expose and see. You can go to investigations as I conclude. And can go to investigations. So then from there, if you receive this patient, you do the conventional head-to-toe examination. After the primary survey, you may need to do other things like attaching the monitors, do the ECG, see what is the rhythm like. Then from there, that's when you would want to maybe do a point of care ultrasound that could give a clue if maybe there is maybe hydronephrosis, maybe reduced renal mass, maybe echogenic kidneys and all of that. So that's very, very important. And then investigating, then we have investigations that are strict baseline and those that are actually focusing on kidneys. You may do a CBC. If you find someone having maybe neutropenia or signs of infection, it could actually mean that because CKD is related with low immunity and predisposition to high infection, they could be having anemia that be normocytic pneumochromic anemia because of low erythropoietin. You would want to do their RBS if they are diabetic, but even if you don't know someone is diabetic until you've done their RBS, unless it is clear from history, if they are diabetic, you want to go ahead and do HbA1c, see how has their glycemic control been over a month. Do renal function tests and extended electrolytes, as you see. These two conditions can actually lead to electrolyte imbalances. So if someone has severe hyperkalemia, then you want to manage it depending on the level. You want to do ABGs if you have the opportunity to do that. If someone presents with bleeding, you may want to do coagulation test, PT-INR, you want to do HIV test and all of that. You want to do blood smear for malaria, especially in pediatric population, because you see many severe malaria in children causes actually AKI, which if not managed well could lead to CKD. Then if you're doing urinalysis, you can do urinalysis, then you can do urine protein and urine electrolytes that can help you do then you can see you do urine electrolytes like sodium and urea to do the fraction excretion of sodium, fraction excretion of urea, and all of that. Imaging is ECG can help you see the symptomatic hyperkalemia, but you could still detect that from electrolytes. Then chest X-ray, in case someone has come with the difficulty in breathing, for example, those who have come with the pulmonary edema, you want to know if there are other findings that you want to find out. Abdominal ultrasound scan, and for those who have come with altered level of consciousness, like in uremic encephalopathy, you want to find out more. Is it only just uremia or there is something more? And you do the brain CT scan. So once you've investigated them, then you can have the proper understanding of the patient. Then you call the team that actually need to manage this, because you will not manage these patients alone. You need a whole team on board to see how you can manage this. Thank you so much. Thank you.
Thank you so much, Dr. Joseph, for the wonderful presentation. In case you have any questions, please keep typing them in the Q&A section. They're going to be responded to. In case you feel like speaking, you can raise your hand and you'll be selected. Next on our agenda, we are going to be hearing from Dr. Robert Kalyesubula about the ED management and complications of AKI and CKD related emergencies. Yes, Dr. Robert.
Thank you very much. Can you see my screen? Hello? Are you able to see my screen?
Yes. Yes.
Thank you very much. So I would like to appreciate SEED and ECHO for inviting me to present today. And also thanks to the previous presenters and my colleagues who are going to present later. So I'm going to talk about acute kidney injury and CKD management after we've seen the presentation and what has happened. So really, AKI emergencies, I'm going to concentrate a bit on fluid therapy. I'm going to talk about the furosemide stress test, which can be used by many people to determine how people are going to respond to treatment. And then I will also emphasize when dialysis should be done, what type of dialysis, and also let you know that AKI can cause chronic kidney disease, and then talk about a slightly management if we have emergencies in CKD. It's a big topic. So AKI is the AKI emergencies, as have been shared by Dr. They have several complications. One of them is sudden loss of kidney function. When you have sudden loss of kidney function, this could occur when you have severe hypotension, but it will also occur when you have intrinsic renal disease or when you have the vascular disease. But commonly with vascular disease, when you have destruction, rapid destruction of the blood vessels, like commonly what happens in rapidly progressive glomerulonephritis for people who have focal segmental sclerosis or people who get infection and autoimmune diseases, that might be the case. Another complication is severe dehydration. We have fluid overload, electrolyte imbalances, and medication toxicities. I'm going to try to talk about a few of these and how they are managed. So first, I would like to talk about the fluid management. The type of problem when you have fluid and electrolyte imbalances, you should know the type of fluid to use, when it should be best used. So we have crystalloids here, where we have mainly, we can have hypotonic crystalloids like the D5 and half strength normal saline. Then you have isotonic normal saline Ringer's lactate. You can have hypertonic. Commonly here, I think individuals use 3%. And then on the other side, you have ionic and non-ionic. So when do we use some of these fluids? It's important to appreciate that Ringer's lactate versus normal saline, these are the two commonest fluids we have. It's first important to appreciate the composition of this. Ringer's lactate has a bit of less sodium, and it has a bit more potassium, and also has bicarbonate, as opposed to the normal saline, which has sodium at 154 and chloride. So this is a bit more. That's why it's very important, because it doesn't cause much acid-base disturbance. Of course, there's a risk of possible clot formation because of the calcium. You know, calcium is used in the coagulation pathway. So in case any patient has any coagulation disorders, clot formation can be elevated. Because there is some lactate there, it also increases the lactate, particularly in patients who have shock liver, where their glycolysis and glycogenolysis gets disturbed. But of course, it is the most physiological. Most people don't know this. They think that normal saline is the most physiological. So it is important in correcting when you have volume loss, when you have acidosis, and when you have electrolyte imbalances, and when you have diabetic ketoacidosis or after surgery. Like in the patient we are treating, Ringer's lactate would have been a good solution to use. We should avoid it when we have severe liver failure and of course in heart failure. Normal saline is good because it increases the intravascular volume. It has a small risk of metabolic acidosis and might actually increase interstitial edema. It might not be very good to use when people have severe hypertension or when they have congestive heart failure and liver failure or renal failure. Basically food overload status, but it's very good for dehydration and when the effective arterial circulatory volume is reduced, and when you have water deficit like in diarrhea, shock, and also very good when you have brain injury, because sometimes you also use hypertonic saline. In DKA, you might also use it, and then when you are doing irrigation like post-surgery, like after TURP, it is the good drug to use. And then it was formulated to be a good driver when you are giving it along with the other drugs. Now, when you come to colloids, you actually have albumin. I'm going to do an X. I'm an ardent X person. I think one of the most abused drugs in Uganda, especially for critical care, is the albumin. So I will not have enough time to talk about it today, but we usually use it for emergent shock when we have low plasma volume or when we have severe hyperalbuminemia. That is an albumin less than 2 grams per deciliter or 20 grams per liter. Please mark that. Most people, you see an albumin of 3 and people begin to administer albumin, very expensive, costs go high. When you have acute burns, this is the time to use this because of the large surface area of burn. Then when you have resistant nephrotic syndrome, especially when you have severe hyperalbuminemia with nephrotic syndrome with continuous loss, studies showed that when you have spontaneous bacterial peritonitis, especially if it is demonstrated, you use this for 3 days, given at 1 gram or 1.5 grams per kilogram body weight. And then for plasmapheresis, when you are replacing fluid. We also use it in liver cirrhosis. You should take caution because it has oncotic pressure. It can worsen pulmonary edema. It could also worsen heart failure and can also make severe anemia worse because you increase the volume and then the HB goes down. You saw in our patient, when the doctor was presenting, this patient had a very high HB. This patient was dehydrated and was hemoconcentrating. So really he needed volume, which the doctor did, and you saw everything trying to normalize. Also, you do not use it as parenteral nutrition because albumin has a short half-life and it gets depleted very fast. Use alternatives. Its cost effectiveness is questionable because it's very expensive, especially in our setting. Now, in case someone has dehydration and they come to you, and people have talked about a fluid challenge. So this is when you infuse a certain amount of fluid, usually 300 to 500 mils, and then you measure the parameters to see if the volume increases. This is, you are testing to see if the patient is going to respond to your therapy. Of course, you know that the usual measurements of hypotension, postural drop, dry mouth, dry skin, especially in the adults, gets very difficult, and especially in the ICU when people are on vents, even the other criteria we usually use for hypotension become quite difficult for measuring the level of hydration. So if you have other issues of heart function, fluid delivery, you could use the fluid challenge to test where you are. I will talk about the furosemide stretch test later, and but this one way to do it, but you have to look at your patient before you do this, and you also have to look at the type of fluid. It's better to use a crystalloid, and then the rate of delivery is usually 250 to 1 liter in 30 minutes, and then use crystalloid when they are indicated. So the people you are going to do this in are people who are hypotensive, secondary to hypovolemia, especially when their mean arterial pressures are less than 65. People in the villages can also calculate the mean arterial pressure. I don't think I have enough time to discuss that, but you can use the systolic and diastolic, 1/3, 2/3 diastolic. Then you can get your map, and that can guide you on treatment. But usually these people would really be hypotensive. Tachycardia due to hypovolemia, when they have reduced urine output, you had the doctor talk about it. If they are producing less than 0.5 mils per kilogram body weight per 2 hours. We have actually done a study where you can monitor urine output and actually use relatives, and we have gotten very good results. We are about to publish that. When then the low CO with underfilling, especially when you have invasive cardiac monitoring, you might not know. Of course, you have safety limits, as I shared earlier. Now, the challenge also comes in, how do you use the fluids in AKI, especially when people are fluid overloaded. Here, you might have to restrict the fluid in edematous patients or patients who are oliguric, producing less than 400 mils in 24 hours, or those who are anuric, producing less than 100 mils of urine in 24 hours. So your fluid intake ideally should be guided by the principle of what the patient puts out in the last 24 hours. The urine output plus 500 mils plus minus, depending on whether they're on vents and they have extra losses, would guide you on what the patient would be required to take the next day. If the patient is overloaded, restricting salt helps. You try to avoid hyperkalemia. And if the patient has pre-renal AKI, give them a fluid challenge. If there's no response and the patient is fluid overloaded, then you use furosemide. So the use of furosemide should not be done all the time. So again, when you come to fluids and AKI, those who are non-oliguric, for instance, they might have sepsis, aminoglycoside interstitial nephritis, which is induced. You watch out also for acid-base balance and hyperkalemia. For those who are oliguric, particularly as I shared above, usually this is the ATN, which may last up to 2 to 3 weeks. So you do the urine output and it's less than 400 in 24 hours, or the urine output, as I said, up there. Here you have to restrict fluid and salt, and then watch the potassium. You can use dextrose 5 or 10% to replace the fluids as needed, and also provide them some energy, especially if they are catabolic. When you are in the diuretic phase, this is where the issue comes. When the kidney is recovering, it sees all the trouble that is around and tries to come and act fast. So the tubules are recovering, and therefore you get, there is less concentration of urine. So you go into the polyuric phase. These people can produce up to 7 liters of fluid. So here you replace the fluid with half-strength saline. You also include the potassium because it is lost. And here the rule of thumb is to replace about 70% of the previous 24-hour loss. I've seen doctors trying to follow the 10 liters. The patient puts out 10 liters, you give him 10 liters. That's not right. You are going to continue driving the polyuric phase. So you want to interrupt the polyuric phase, give less than they put out if they are more than 3 liters in 24 hours, which is considered polyuria. So this is sometimes you give the diuretics and they are not working. So there's what we call furosemide resistance. Because of time, I didn't go into the details of that. You have to appreciate where each drug acts. so that you can help your patient. We have osmotic diuretics, which act in the proximal tubules. Of course, they inhibit absorption of glucose, which is osmotic. It breaks down the water. We use this when we have cerebral edema, but we also use mannitol when we have rhabdomyolysis, where we want to increase the flow into the urinary system. We have the loop diuretics, which are the sodium 2 chloride potassium channel blockers. Here, of course, when you use them, they send the fluid to the distal, so you might have to do what is called sequential blockade of the kidney. So you block the loop, then you block the simple sodium chloride channel, and then later you also block the ENaC, the epitheliosodium channel, which is the distal one. So here, this drug should be given in tandem. The loop diuretic should come first, maybe 1 hour before the thiazide diuretic, especially if your patient is food overloaded and they are not responding, and perhaps you don't have access to dialysis. That's a very important management skill to acquire. So the use of diuretics is not beneficial for AKI treatment in kidney-related, and if kidney endpoints are considered, but it helps in helping the patient to manage the patient. So also when you have oliguric renal failure, you might want to turn it to non-oliguric, so that you are able to manage the fluids well, so the Lasix can help you there. So it's very important to identify which patients would benefit from the Lasix. And this is the test you do. It's called the furosemide stress test for AKI who are at risk. So the cutoff of predicting acute kidney injury, like the doctor said, of course, you use the rifle. We no longer use that very much because of this complexity in measuring. We use the acute kidney injury network. But if the patient puts out more than, so the way you do it, if the patient has kidney failure stage 1 to 2, a clean stage 1 to 2, you administer furosemide in the subjects. If the patient has not had any furosemide before, you give him 1 milligram per kilogram body weight. And if they've had furosemide before, you give them 1.5 milligrams per kilogram body weight. After you've given them the test fluid, 500 mils to 1 liter, depending on your assessment of the patient. Then after 2 hours of your load, your administration, you look at whether they are putting out more than 200 mils of urine. If they are putting out more, then you know that the loading dose will work and you continue giving furosemide. If that test is negative, furosemide is unlikely to work in this type of patient. And if you keep increasing the dose, you might actually cause more complications, particularly deafness, because the ossicles also have channels that are similar to the ones in the tubule. So I'm going to manage just a few electrolyte imbalances for us. And this is hyperkalemia really, because that's what our patient had. The doctor did a very good job in managing, but here the first thing is always, if the potassium is more than 6.5, you can stabilize the membrane using calcium gluconate, and then you can shift the potassium into where it is more, the intracellular, by using insulin or albuterol. Here mainly people use salbutamol, but you need to use very big doses. Or you excrete the potassium by giving furosemide if the blood pressures are okay, or sodium bicarbonate, or you use the binders. Here we mainly use Kalyesubula. The newer ones have not yet come. And if that fails, you actually have to do dialysis. Now, we move on. We move on to management of hypernatremia, like what our patient had. So our patient had hypernatremia. I think the sodium, if I recall, doctor, was 165. But also you remember this patient had high hyperglycemia. So this becomes very difficult for you because it means that actually the sodium was much higher. Normally when you get hyperglycemia, what you get is pseudo-hyponatremia, because the sodium pulls the water into the tissues, then they dilute the sodium. So the fact that this patient had 165 millimoles, it means that totally this patient was so dehydrated. So in such a patient, you actually have to correct for the sodium for every 100 milligrams of glucose above 200 milligrams. when you measure them, you have to add on a certain level of potassium. So in essence, our patient's potassium was much higher than what was said. I saw someone asking that, why didn't you use 0.45 sodium chloride, or why didn't you use 5% dextrose? That was a tricky patient because they had hyperglycemia and then they had hypernatremia. It is usually the opposite. So I think it was because the patient was dehydrated. So in management of hypernatremia, the onset of occurrence of the dysnatremia is very important. If it's acute, less than 48 hours, you do rapid correction with a maximum of 12 millimoles per liter per day. And then if it is chronic, more than 48 hours, you can do slow corrections. But again, the correction again depends on the volume status of the patient. If they are hypovolemic, then you have to do initial volume resuscitation using crystalloids, and then you switch to 5% dextrose, and later you can also use half isotonic saline. If they are euvolemic, usually use 5% dextrose, and you can actually add on a diuretic if their pressures are good to make sure that the sodium gets excreted. If they are hypervolemic, you use 5% and a loop diuretic. You can calculate the effective food water deficit using this formula, but I'm not going to go into it. I hope these slides will be shared. But you have to calculate the volume deficit. But since most of you are Gen Z, you can just go online and you calculate the food service. I thought I should also talk about this, which came in our MCQs, the sick days medication list. When someone is very sick, it doesn't matter what is causing their disease. There are certain drugs that worsen the conditions irrespective of the patient. So you have to hold them. These include opiates, sulfonylurea, angiotensin receptor blockers, angiotensin enzyme inhibitors, diuretics, metformin, angiotensin receptor blockers, and NSAIDs, as well as our good drugs, the SGLT2 inhibitors, which we use in diabetics, heart failure, and now the key hallmark of managing kidney disease. So this one found what we called OS admins, which you can use to recall this information. So sick days are very important. Some drugs have to be stopped. If everything fails, you have, the word here is intractable. When you have intractable fluid overload, intractable acid-base balance, which is not responding to your bicarbonate replacement, if you have intractable hyperkalemia, you have given the dextrose, insulin, you have given your KXLate is coming to 48 hours, the potassium is not coming down, the patient has ECG changes. This is where you actually now have to go in and you actually to do the hemodialysis. For the acute illness, you can use actually peritoneal dialysis, but doesn't do a very good job because it's slow as collecting electrolytes and fluid. But sometimes you don't have choice. You have to use it for longer. But you would use a cycler, which we don't usually have in Uganda except in one place. So most of the dialysis here is array and most is improvised. So we mainly use hemodialysis where you have the blood taken from the person, taken into one access, and then they clean the blood and give it back to the patient after they collect. They can also remove fluids as indicated. So the indications, as I shared earlier, intractable food overload or refractory hyperkalemia, severe metabolic acidosis. You can also have uremia, particularly uremic pericarditis, neuropathy, or uremic encephalopathy, or if you are bleeding in the GI. Sometimes people bleed in the GI, then they cause the urea creatinine dissociation. You see the urea is very high, but the creatinine is not very high. If they are not on the steroid, please consider them as having bleeding, especially if you've given them steroids for some point, which might cause that. So sometimes there is overdose with diazepam drugs like salicylate, methanol, and lithium. Drugs can cause trouble. Those are dialyzable and they can be removed with dialysis. So the timing of dialysis has always been a key of question. I think someone was talking about this. So there is a trial which was done, and the New England Journal of Medicine is our best for medicine in the world, when they looked at about 128 multi-centers. They noted no difference in mortality after 90 days on those who were started on dialysis early within 12 to 24 hours, and in those in whom it was delayed up to 72 hours, unless they had a very clear compelling indication. You can see here the forest plot. I hope I'm not disturbing you, but you see the lines are similar here. This is the y-axis, the x-axis. You can see there's no difference between the standard treatment and those where it was accelerated, which is good for us people who come from resource-limited setting. Not everyone that has AKI needs dialysis. They should have very clear indication for you to begin doing dialysis. You need to do all the things that were mentioned above. I'm afraid of time. For those, we don't have most of, but there are many techniques for renal replacement, but here we usually use intermittent, but you can do other forms of dialysis. That is a bit specialized. Now, let's just go and see what we should do, what the ISN recommends using the 5 R's, which was also an objective for that. So you have to do the risk assessment. You identify those individuals who are at high risk, as was shared by our first presenter, second presenter, and then you recognize. The key here is you have to recognize AKI. If you miss AKI, then you'll end up going into when it's very late. So early and sequential serum creatinine and measurement of urine output. If a patient gives you no drop in 3 hours of urine, you should get worried. If in 6 hours they are giving you less than 0.5 mils per kilogram body weight per hour, then you are really in trouble. These individuals will have AKI. Actually, the urine output sometimes comes before the creatinine goes up. Because for the creatinine to go up, you need to destroy over 50% of your kidney function. That's about 1 million nephrons. So that takes a long time. So creatinine lags behind. And then the key other R is response. You have to intervene. If it is sepsis, treat the infection, avoidance of nephrotoxins. Don't give these people NSAIDs. The person has a BP of 90, over 50. What the hell are you giving him diclofenac for crying out loud? We've seen this. Please don't do that. Of course, it's important to use the protocol-based food therapies and do good blood pressure management. Blood pressure can be too high or it might be low. It needs to be managed, then prevent harm by treating the causes and complications. Drugs cause a lot of trouble. I've told you about sick days. Stop the drugs you need to stop. Don't give the drugs that you don't need. People were asking about the role of haloperidol in this patient. Was it really necessary for it? Of course, it has a risk of causing hypotension also. I see a lot of, when I see you, it's like you just give every drug that comes your way and you treat people symptomatically and even 4 days down the road. The symptomatic treatment should last for the 24 hours where you should be able to know now the cause and you begin correcting the patient. If you are still firefighting at 5 days when the patient is in ICU, then something is totally wrong. So we need to find the cause and manage it. Then we do renal support. As you've said up there, the indications are clear. Of course, if you don't have the dialysis, you can actually also do conservative management by treating the symptoms. Then we rehabilitate these individuals. I won't belabor you into this, but you can go to the ISN website. We've developed this kit in collaboration with the International Society of Nephrology. If you are really keen and you can develop a protocol, you see the patient characteristics who's likely to get, you look at the exposures, then you look at the symptomatology, you score the patient. If the patient has more than 3 points, then they are at high risk. You really need to take care and follow up these patients by doing a serum measurement or at least a urine dipstick. For those who don't have access to this, you monitor the urine output and then you intervene. Then you can stop. You can actually be able to stop you can stop the AKI. And the word is stop. Look for sepsis, manage it, identify the source, treat it, look for toxins, including drugs, particularly the ones we give, optimize the blood pressure and blood volume status, rehydrate the patient as needed, then prevent harm. That is the stop for you. You'll probably get this slide. So this approach is the tool we have developed you can use it and you'll actually be able to manage AKI. I'm shifting gears now. I don't know how I'm doing on time. I think I was told I had 30 minutes. So now I'm shifting. This is a paradigm that is important for us to appreciate. When you have, 1 second. Okay. So when you have acute kidney injury, it lasts about 7 days. For the long time, nephrologists didn't know what to do between the 7 days and 90 days. We now have a new paradigm, which is acute kidney disease. Acute kidney disease is when the injury persists beyond the 7 days. And when it goes beyond 90 days, like doctor said, you now have chronic kidney disease. And of course, at every level here, you can reverse the injury if you do prompt recognition of and treatment, if you avoid nephrotoxins, if you use the 5 R's that I discussed up, you could reduce mortality, you could reduce cardiovascular complications, and even death. The peculiar causes of kidney injury in our population, low middle income countries, were ably discussed by the first presenter. I won't belabor those. We've published work in this work in seminars of nephrology. You can actually go and get it. I was the first author to this, and it's a very good read. Go and read it. Then I also saw in the chat someone talking about how do we know. So CKD emergencies, I decided to bring this here. These are basically end-stage kidney disease when you have total kidney failure, the same electrolyte imbalances, which I'm not going to repeat, volume overload, and uremic complications. So here you use the RAEO indication for dialysis. Acidosis is the pH less than 7.1. Electrolyte, remember, refractory is the word. Intoxications, the person having alcohol, salicylate, lithium, and other dialysable things. Fluid overload, particularly in heart failure. Then have uremic pericarditis, uremic encephalopathy, and neuropathy. Again, these are the indications for dialysis, even for the CKD. So for the CKD, again, the question is, when do you initiate dialysis in people who have CKD and have those, if they don't have any clear complications like we've talked about here? This study was done in about 3,000 individuals looking at 32 centers, and they followed up these individuals for about 2 years. They actually showed that if you start, they looked at people who had a GFR of 10 to 15, and those who had a GFR of 5 to 10. And they said, should we start dialysis immediately? Well, when they followed up these individuals, there was no difference in the people in whom the dialysis was started early and those in whom it was started very late, clearly showing you that dialysis should be based on the symptoms of the patient. This is where you go to the adage that treat the patient rather than just treating the disease the patient has. So here we rely on symptoms to treat these individuals. We don't have very many dialysis units in Uganda, but we are trying. This is a study that is soon going to be published by Kasime and myself. We've done a review to show AKI management in Uganda. Please wait for it. I'll be sharing it on X soon. In fact, I think the preliminary has been shared, but it shows you where all the dialysis units are in Uganda. We also have the CRT at TMR and at the Uganda Heart Institute. But of course, you should continue advocating for increasing availability of these services in Uganda. That's the key to take from there. Then whenever you are managing hyperkalemia, remember that diet plays a very important role. Look at the foods the person has and try to moderate them. The things that could have low potassium are actually the cranberries, apple, corn, lettuce, pineapple, and string beans. So these can be given to our patients. They have low potassium. It's actually should be, they have less than 100 milligrams per serving. A serving is equivalent to your fist or the patient's fist as you are looking at it. So I hope I've not overshot time. So in summary, I've told you that AKI is common, especially in the ICU. I've also told you that food therapy should be clearly thought out and guided by the patient's status. I've taught you how to do the furosemide space test and how it helps you to determine who would benefit from the furosemide. We've talked about the indications of dialysis and when they should be used. We've talked about AKI as a cause of a CKD And I've also told you, though not in clear terms, that dialysis is very expensive. So the best way to manage these individuals with AKI and CKD is actually prevention using the 5R approach to stop AKI. I want to thank you very much once again for allowing me to present to this august audience. Back to you, Chair. Thank you very much.
Thank you so much, Dr. Robert, for the wonderful presentation. Next on our agenda, we are going to be hearing from Mr. Patrick Winter about the nursing care of a patient with AKI and CKD-related emergencies. But please keep the questions coming. Just have questions regarding our presentations. Please keep them coming in the comment chats or in the Q&A section. Thank you.
Okay, yes. Good afternoon, everyone. Thank you to the previous panelists for the great presentations that they have given us. I think they have really laid a very good foundation for me and done most of the work. So I'm going to talk about the nursing management of AKI and CKD related emergencies, and in particular, I'm going to use the nursing process. So most of the panelists and the previous presenters have already defined AKI, and my definition really doesn't differ very much from theirs. However, when we look at the nursing process, this is a systematic approach to client-based care using the 5 sequential steps. Basically, we are going to have to assess the patient, and from our assessment, we have to develop a diagnosis, and then plan depending on what we have diagnosed the patient with, and then we go ahead to implement our plan and then evaluate how successful the plan has been. So in the assessment of the patient, definitely you need to take a detailed history and conduct a physical exam. It is also important to take the vital signs of the patient. We have all been seeing how in the previous presentations, we can be able to infer that the patient is doing well or badly, depending on how our vital signs are doing in terms of normalcy. So you can also look at the orthostatic vital signs, and you can be able to infer whether the patient has hypovolemia, depending on how the vital signs are looking. Then the history and the physical exam can give you a clue on the possible causes of the AKI and whether it's pre-renal, renal, or post-renal. I think Dr. Ahimbisibwe was very clear on the causes and on how we can have pre-renal, renal, or post-renal AKI. Then in the diagnosis, you can develop a nursing diagnosis depending on the NANDA international list. After you've done your physical exam, and then you look at the problem, etiology, and the defining characteristics. If we are looking at the AKI and CKD related emergencies, I was just giving an example. You can come up with something like neurological impairment related to the increased urea. If someone has increased urea, they can end up in the uremic encephalopathy, which can cause neurological impairment, and the patient may be confused or aggressive. And you can also develop other diagnoses. We have talked about the oliguria and the anuria, reduced urine output and completely absent urine, as well as shortness of breath. All these can be developed after you've assessed your patient. So in the planning, I combine all these 3 areas, planning, evaluation, and implementation. And if most of the patients that have AKI or CKD related emergencies definitely are going to end up on the ward as inpatients. And what you need to do for them, especially as the nurse, is to monitor their vital signs. The frequency will depend on the severity of the condition. How often should you do the vital signs? So the frequency really will depend on how the vital signs are. If you have a patient who is hypotensive, you may need to do those vital signs more often. And also, if you have a CKD patient who is hypertensive, you may need to take the vital signs more often than a patient who has vital signs that are within the normal range. And then you need to monitor the output and the input. We need to be very clear on how much the patient has received and how much they have put out. So if the patient, it would be good if you could get the patient catheterized, you put in a Foley's, and you get the urine measured by the hour, or at least 2 hourly. And any fluid that the patient receives should ideally be measured. So you can help educate the family to measure whatever the patient will be receiving in case the patient can take orally. And then you need to monitor the mental status changes and the level of consciousness. We have talked about how increased urea can be able to affect the mental status of someone. So you may need to use the Glasgow Coma scale to be able to know and trend on how well the mental status is doing. Then patients who have AKI and CKD usually need daily patient weights. So you need to take the weight of the patient to know how much fluid this patient has gained. This ideally should be on a daily basis. Then you have to administer the drugs as prescribed and ensure renal dosage and dilution. If you have a patient who has AKI or CKD, you may need to dilute their drugs further to limit the damage to the kidneys. And also, most of the patients, if a patient has AKI and CKD, they may need to renal dose. So they may not need to get the usual dosage for weight and age. It may be less. So as a nurse, you should be aware of this, and you should encourage the physician in case they have not implemented this. Then patient education on the condition, as well as the nutrition. Dr. Kalyesubula has really been very elaborative on how we can get a diet that is renal friendly. So as the nurse, you should educate the patient under your care on what AKI and CKD is like and how nutrition can affect them. So a renal diet is encouraged, and this is low in sodium, low in potassium, and low in protein. Then you assess for periodic independent edema. Then you need to escalate emergencies appropriately, because you're going to be having this patient under your care longer than the physicians or the other doctors, because nurses, we are really always on the ward. So any emergency that you note a decreased mental status, if you notice that the patient is their respiratory rate, they're becoming more tachypnic, their respiratory rate is increasing, the shortness of breath is becoming worse, you need to be able to escalate these emergencies appropriately. And if interventions must be done, they are done in a timely manner. Then, of course, we need to take off labs as ordered. Dr. Ahimbisibwe really gave us a panel of a number of investigations that can be done when you have a patient who has AKI or CKD. And this should really be done in a timely manner for interventions to be done. If you need to take off a CBC, RFTs, APGs, to look at the different electrolytes, you need to do this very quickly. Of course, assessing for heart sounds to know whether we're becoming overloaded, whether the fluid overload is affecting the functionality of the heart. And a couple of patients who have chronic kidney disease, already have established cardiovascular disease. So it is important to make sure that it's not becoming worse. Then you may need to do a 12-lead ECG. Dr. Kalyesubula really gave us a sort of like a protocol on hyperkalemia, and this is where the 12-lead ECG is really important to know whether the hypokalemia is causing changes in the patient's heart rhythm or causing arrhythmias, which can be an emergency that needs to be attended to very quickly. Then the warning signs, of course, when you're caring for the patient, you need to be aware of warning signs that need an intervention quickly. Confusion, that could tell you that we are getting worse. The urea is really increasing and is affecting the brain of the patient. The urine output, if it's less than 0.5 mils per kg per hour, you need to really follow up at least every 4 hours to know how it's doing. Then hypotension, it's going to affect perfusion and cause further injury to the kidneys. Shortness of breath, extreme nausea and vomiting, itching skin, which is also related to an increased urea in the body. So basically, for the nursing care, you need to make sure you assess your patient appropriately, you implement your plan, and you escalate appropriately to the medical team for interventions to be done in a timely manner. Thank you for listening.
Thank you so much, Mr. Patrick, for the wonderful presentation. Next on our agenda is the Q&A session. In case you have any questions, please raise up your hand, you'll be selected. Or if you can type in the comment section and we shall read it out and answer them. Feel free to raise your hand if you have any questions. Okay, in the Q&A section, we had some.
That's it, I'm up.
You can speak.
The chocolate.
But you can unmute and speak. Gilbert, your hand is raised up. You can unmute and speak. In case Gilbert is not ready to speak, you can hear from Chirabo. Yes, Chirabo, you can unmute and speak.
Okay, greetings to everyone. I appreciate for this CPD program, and my question is, we have very many clients. Okay, at times people who come in with that lower back pain, different kinds of back pain, or the flanks, and most of them we know, as local people say, my kidneys or what. So is there a unique way of identifying pain secondary to renal injury, to different other pains of the back and the flanks? That's my simple question. Thank you.
No?
Good afternoon.
Yes, Gilbert, thank you so much for that question. Gilbert, in case you're ready, you can also unmute and speak.
During pediatrics, this was a very good presentation. However, my concern, we have so many. Can you hear me now?
Yes, we can.
Yes. I'm called Dr. from pediatrics. My worry is about the number of getting at the moment with the AKI and CKD due to the present conditions in our wards. But now we have to manage them and how to refer them to Mulago. Because they are in a way how the implementing partners, our professor, Dr. Kalyesubula, how they can plan for this problems. Because all of them have
Sorry, Gilbert, for the poor network. If you can type your question in the Q&A section, and it will be responded to. Okay, here are some of the questions that in the chat. One person was asking how to calculate the fluid needs for the patients with concurrent azotemia and fluid overload. Another question, how does pancreatitis cause body volume depletion?
Hello?
Next on our agenda, we have is the post test. The link has been. Yes, you have more questions.
Hello.
Yes.
We can have Dr. Robert respond to our questions.
All right. Thank you very much. I think the first question is around differentiating pains, those in the back and where they come from, particularly in people who might have renal involvement. Usually kidneys don't cause loin pain unless they get infected or when they have a kidney problem. So because the kidney is also supplied by it has a lumbar and SC2 to S4. So the pain is usually sometimes radiates to the abdomen and the back. But in order for you to differentiate such pains, you really have to investigate your patient. You have to look at the urine. If the urine is infected, they might also have a corresponding pyelonephritis. Then also, if they have, for instance, if you are able at all to do the ultrasound scan, it will help you very much. Kidneys will get pain if they are obstructed, or if they have a mass that stretches the capsule. The rest of the pain is usually from the back when people have bone problems that squeeze the nerves. And because the nerves fall a dermatome, that pain usually goes much lower, things like sciatica, and it follows that path which nerve is being pressed. So you really have to take a good history and also examine your patient. Also, kidney pain is usually localized in the lower part. So you hit on the lateral part of where you have the kidney rotated. If you hit at the back, they will have tenderness there. I think the second question was around how do we determine which kinds of food and how much food do we give for the patients. You have to assess your patient's volume status. We can use the vital signs, blood pressure, heart rate, respiratory rate. Then urine output also helps you. For those who have access to the central venous pressure, then you use the jugular venous clinically, and you can also look at the patient who has edema. And then also you estimate the deficit based on how much blood volume was lost. There are sometimes insensible losses like sweating, you look at those. And then when you come to correcting the food, there are certain formulas that are used. You can use the rule of 4-2-1, where you give 4 meals per kg per hour for the first 10 kilograms, and then 2 meals per kg per hour for the next 10 to 20. This is usually commonly used in children. And then you give the last 1 meal per kg per hour for those who have greater than, for any extra kilograms above 20. Some people use the Parkland formula, which is to give really 2 to 4 meals per kg per hour in adults. And then for children, because of their large volume, which is above 70%, you have to give greater meals of about 4 to 6 per kg, but using the other formula might be better. Of course, you always, as I said, you always have to do maintenance food. Once you correct the deficit, if the problem has not been resolved, you have to continue. If the area has not gone, you continually have to assess the patient and then also consider replacing the electrolytes, especially if people have fever, sweating, diarrhea, vomiting, or if they have ongoing blood losses, and sometimes when they have increased insensible losses. For instance, we've talked about patients who have burns, those lose a lot of fluids. You have to replace the electrolytes as well. That was the second question. The third question was about what? I forget the third question, moderator, someone help me. All right, I think I missed the third question.
Yeah, the third question was, how does pancreatitis cause body volume depletion?
Oh, pancreatitis. You know, pancreatitis is a very inflammatory condition. So basically what happens when you get pancreatitis, you get a lot of inflammation. And so that inflammation, actually, because with pancreatitis, you know, the pancreas is able to keep the digestive enzymes. They are usually in an inactivated form. But when they are deactivated, they now eat up everything, and inflammation actually causes the accumulation of fluid. So you get really very serious electrolyte imbalances. But sometimes if you also block the sphincter body, then you will not be able to send in the bicarb, which usually comes from the pancreas also. So you can actually also get electrolyte imbalances. So, but the fluid is because of the inflammation most of the times.
Another question, it's here in the comment section. What is the association of low serum urea and creatinine with kidney malfunction?
What is
the association of low serum urea and creatinine with kidney malfunction?
The association of low kidney function in urea.
Low serum urea and creatinine with kidney malfunction.
When the kidney is malfunctioning, the urea should be high. If the urea is low, then that person has malnutrition. So you have to look at the nutritional status of that individual because urea comes from the protein. So usually the urea should go high. What I talked about was the urea creatinine dissociation. Sometimes the urea goes much higher than the creatinine, and that is when you have the pre-renal injury. Because the kidney, if the tubules are working, because in pre-renal injury, the kidneys are working very well, so they are able to reabsorb every food you are giving it. So the urea goes higher than the creatinine because the food is able to get reabsorbed. So if the ratio is greater than 20, 1 to 20 of urea to creatinine, then you know you have some pre-renal injury. But a low urea is usually a sign of malnutrition. Same with the low creatinine. It's usually a sign of malnutrition or people who are small. I submit. Thank you.
Thank you so much, Doctor, for that answering our questions. Next we have is the post-test. The link has been shared in the comment section. As we attempt the post-test questions, can have closing remarks from our panelists. Can have closing remarks from Mr. Winter.
Yes, yes, good afternoon once again. Yes, I would like to thank City Global Health for the invitation to be part of this panel talking about AKI and CKD related emergencies, and I can say that I have benefited a lot. And my knowledge definitely concerning this has improved, although I was part of the team that was supposed to give out the knowledge. And thank you to the fellow panelists that I was with, Dr. Ahimbisibwe, Dr. Waswa, and Professor Kalyesubula.
Thank you so much for the closing remarks. Next, thank you so much for taking time to log into our session. Kindly turn on your cameras and we take a photo.
Yes, thank you so much, everyone who participated in this eco session. Thank you, the audience. It has been a great session, learning and refreshing our knowledge. I pray we will remember this and apply for the best of the care of our patients. God bless you.
Thank you, everyone. Thank you, City Global. Thank you, my seniors and the entire team online. I, for one, am not that I came here, and I believe I'm going to manage my patients much better. Thank you.
Dr. Irene.
Thank you very much.
Yes, thank you everyone for attending, and I want to thank the panelists for the input they've given. And for sure, as Professor has tried to allude, that AKI is really very much prevalent, and mostly in patients without sepsis or the very critically ill. And so we need to use the knowledge that we have gained so that we prevent progression to CKD. Thank you so much.
Dr. Robert, you can give us closing remarks.
I want to thank the organizers for giving me this opportunity to talk about kidney injury and CKD. Thank you for thinking about the topic. As we have learned, kidney disease can be a danger, especially because dialysis is very expensive. So as clinicians, we should look out for every patient that walks in and needs admission. They are at increased risk of developing AKI, and we solve it, recognize using the 5 R's and stop AKI. Thank you very much for listening to us and attending in big numbers. We hope to see you soon in the next session. Thank you very much to the organizers.
Thank you so much for tuning in. Please switch on your cameras, your videos, and take a snapshot.
Jimmy.